Hello, my name is John Kobashigawa, and along with my colleague, Dr. David Chang, and the Cedars-Sinai Heart Institute, we are happy to present our article entitled Cardiac Allograft Immune Activation Current Perspectives. The purpose of this publication is to provide a review of the mechanisms by which the innate and adaptive immune responses influence the post-heart transplant recipient in terms of hyperacute rejection, cellular rejection, antibody-mediated rejection, and chronic rejection. We'll be discussing these forms of rejection, their detection, clinical presentation, and treatment. This article will also review potential strategies to prevent rejection in immunologically high-risk patients, including immune monitoring strategies and rejection surveillance.
Humans have both an adaptive and innate immune system which work in conjunction to ward off pathologic infection. While there is a significant interaction between the innate and adaptive immune systems, to date, modulation of the adaptive immune system has historically been the focus of chronic immunosuppression post-heart transplant. Most standard chronic immunosuppression post-heart transplant is directed at suppressing T-cell activation by suppressing T-cell signaling or T-cell proliferation, as activated T-cells are a main mediator of the adaptive immune response and contribute to heart transplant rejection. Post-heart transplant, the risk of rejection is highest in the first year, with the incidence of rejection approximately 25% according to 2010 registry data. This is a significant decrease from prior eras when the risk of rejection in the first year was approximately 33%. Hyperacute rejection can occur immediately post-transplant and is manifest by critical cardiogenic shock and profound organ hypoperfusion. It is thought to be an immunologic process caused by preformed recipient antibodies to the graft. Fortunately, hyperacute rejection is a rare clinical scenario due to the development of the prospective cytotoxic crossmatch and more recently with use of the virtual crossmatch.
Acute cellular rejection is primarily T-cell mediated process with graft infiltration by leukocytes and macrophages. Acute cellular rejection requiring treatment may present insidiously. It may also manifest with new symptoms of heart failure, with rhythm disturbances, or with even cardiogenic shock. The diagnosis of cellular rejection is definitely made by endomyocardial biopsy, with grading based on standardized guidelines. Risk factors for acute cellular rejection include higher number of HLA mismatches, age of the recipient, female gender, race, and use of induction therapy. Subtherapeutic immunosuppressant trough levels also predispose recipients to cellular rejection. Antibody-mediated rejection, or humoral rejection, was first described in 1987 and is increasingly recognized as clinically important. Due in part to antibody sensitization in transplant recipients, antibody-mediated rejection occurs in approximately 15% of heart transplant recipients with a wide range of clinical presentation. Diagnosis of antibody-mediated rejection is based on histology and immunohistochemistry. It has been associated with hemodynamic compromised rejection, cardiac allograft vasculopathy, and increased mortality. Chronic rejection, also known as cardiac allograft vasculopathy, remains a leading cause of morbidity and mortality after heart transplant. It is reported to impact 50% of heart transplant recipients within 10 years after transplant, and in contrast to native coronary disease, is generally thought to be diffuse concentric intimal thickening of the coronary arteries. Routine angiography with intravascular ultrasound is recommended to evaluate for the presence and severity of this chronic form of rejection.
Treatment of heart transplant rejection depends on patient symptoms and the severity of the rejection episode. In augmenting immunosuppression, clinicians must balance the risk of infection with the potential for improvement in graft function. It should be noted that treatment for antibody-mediated rejection in asymptomatic patients with preserved cardiac function is controversial, as its benefit has not been proven. While immunosuppressant therapies are required post-heart transplant to prevent or treat cardiac allograft activation, use of immunomodulating therapies prior to heart transplant is under investigation. Of note, there is evidence that supports desensitization strategies with intravenous immunoglobulin and rituximab prior to renal transplant. In heart transplantation, patients with elevated calculated panel-reactive antibodies may benefit from desensitization therapies to reduce the risk of rejection post-transplant and to expand the number of compatible donors pre-transplant. Cardiac allograft immune activation and heart transplant rejection remain major contributors to morbidity and mortality after transplant. Antibody sensitization presents additional challenges in the care of heart transplant recipients. Further understanding of the interactions between the innate and adaptive immune systems is key to effective immunomodulation. We hope this review contributes to the dialogue and discussion around this important issue. Thank you.
On behalf of Dr. Chang, myself, and the Cedars-Sinai Heart Institute, we hope you enjoy reading this paper.